Welcome to Young Lung Cancer Initiative's Patient Education Series with Dr. Negrao from MD Anderson. He's a thoracic medical oncologist here to share some information about KRAS, the mutation, what we have in store in the KRAS world, and what is here and now. So without further ado, I'm going to turn it over to him to share with you just a little bit about himself and what KRAS really is.
So good morning, everyone. Leah, thank you so much for hosting me. It's really a pleasure to be here and with your group discussing this very important topic. So as you said before, my name is Marcelo Negrao. I'm a thoracic oncologist here at MD Anderson. I've been at MD Anderson now for almost 8 years. So I'm originally from Brazil. I did a good portion of my medical training there. And during my fellowship in medical oncology, I developed a keen interest not only for patient care, obviously, but also for clinical and translational research. And that's where the appetite and the will to come to the US, which is a place where this is still highly valued, and it's still a place where in academia you can really be able to do those two sides of things, be a good clinician at the same time, a good cancer researcher. So that's what drove me to come here. So I was fortunate enough to have the opportunity to do a subspecialty fellowship here in thoracic and head and neck cancers. And then subsequently, I was invited to stay as faculty dedicated exclusively to treatment and research in thoracic malignancies. And that's where I've been ever since. During my period as faculty, I was fortunate enough to get extremely involved and really take the lead on a lot of our KRAS-directed clinical trials, and also had the opportunity to spearhead a lot of important translational research endeavors that I think were important for our better understanding, not only of KRAS mutant lung cancer, but also what are potential treatment vulnerabilities, as well as mechanisms of resistance. And that's what I'm here today to share some of that knowledge with you and your group, and also to discuss what are our current standards of treatment for these types of lung cancers, as well as discuss some potential research opportunities that may be of interest to you and your group.
We're always looking for more education on each individual mutation, really, because there is such a desire to learn what we're facing.
So let's talk about a little bit what is KRAS. So I think your group is quite familiar with what we call oncogenes. So
Yes.
Genes that when mutated are able to drive cancer growth and progression. So some examples of that are EGFR, ALK, ROS1. But in addition to that, you have the KRAS gene, which is also an oncogene. And in fact, it's the most commonly mutated oncogene in solid tumors. So the prevalence of KRAS mutations can be as high as 90% in patients with pancreatic cancer, for instance. But in lung cancer, we know that it's responsible for about 30% of all of non-small cell lung cancers, particularly the ones that have an adenocarcinoma histology. Within that group, the KRAS G12C mutation is the most common. It accounts for about 42% of patients. And the remainder, the other about 58%, would be more frequently represented by the G12V and the G12D mutations, but there are other ones as well. KRAS is a very heterogeneous disease. It's somewhat different from EGFR and ALK in that setting, because we know that the process that drives the development of the cancer can be different from one patient to the other. So for instance, KRAS G12C mutations are extremely prevalent in former or current smokers, so which is something that's very different from your EGFR and ALK population. But at the same time, G12D mutations, for instance, have a very high prevalence in patients that have never smoked or have a very light smoking history. So I think that's the first point I think for the group is that it is different, and you have two potential ways of developing KRAS mutant lung cancer, one through smoking and one that's not.
That's good to know, because I think a lot of people associate KRAS with a smoking history. So I like that that's been clarified, that non-smokers or never smokers or even light smokers could also have that mutation.
So, and then how does KRAS then function? So the KRAS protein is something that all of us have in all of our cells, right? But the KRAS protein, it functions in some sense as a light switch. So you can turn it on and you can turn it off when you don't need it anymore. And when you turn it on is basically because your cells need to divide, they need to grow. So it's really one of those switches that drives that drives cells to divide and grow. But you can turn that off if you need to. That's how our normal cells function. right? But what happens is that when you develop the Kras mutation, that balance gets disrupted and it gets shifted towards being consistently in the on position. So you can't turn the light switch off anymore. And that's when the troubles start. Then that enables those cells to start growing abnormally, dividing abnormally, and spreading, which is also something that's a typical behavior of a cancer cell. So I think that's the second point to note, is that function of the KRAS gene. And I think the third point is going back to the heterogeneity part that we talked about. And this is work that's been done by many investigators, not only within our group, but other groups as well. There seems to be a very important component of KRAS mutant, particularly lung cancer, that's driven by the co-mutations that are identified in the patient's tumor. So what I mean by co-mutations is other genes that are mutated in addition to KRAS. So in that sense, there seems to be three big buckets. I'll focus more on two of them, which are the most common. So one of them is when you don't have a clear co-mutation, or when you have a p53 co-mutation, which is a gene that basically regulates division and growth of our normal cells. So when that gene gets mutated, that process is also affected, and you don't have a good regulation of how your cells grow and divide. So that bucket has historically been associated with a good response to immunotherapy. So treatments that we use to ramp up our immune system to identify and attack cancer cells, right? So that's one very key behavior. But on the other hand, you have another bucket of these KRAS lung cancers that are co-mutated with genes such as STK11 and KEAP1, which are genes that are responsible for the metabolism, the way that our cells break down, for instance, sugar, and the way that they regulate their function, and also the way that they are responsible for producing quote unquote like a healthy cellular environment. So breaking down oxidative stress reagents, for instance. So basically just providing cell fitness for survival. That's what these pathways typically do in our normal cells. But again, when these genes are mutated, all of this process gets disrupted, and that actually starts to be used against you in the sense that the cells become stronger, fitter. They also become more versatile in the way that they can handle sugar, for instance. And we've associated those changes to actually a very aggressive tumor surrounding environment, which is very hostile for immune cells. It's really hard for immune cells to thrive there. And that automatically translates into a very deeply resistant type of cancer to a lot of our standard treatments, particularly immunotherapy and even chemoimmunotherapy.
Okay, so I guess it really depends on if you have these other drivers to how aggressive KRAS will be.
I wouldn't say that it's a matter of aggressiveness. Yes, aggressiveness is a piece of it. Poor prognosis is another piece of it. But I think that the thing that's, from a patient standpoint, that's the most important is that your treatments start to differ, and the effectiveness of your treatments start to become different. And then you start to see some clear needs for novel, more effective therapies.
Okay, so let me ask you this question. So if someone has the KRAS mutation and there are no other mutations in their genetic workup, their biomarker testing, could down the line of KRAS treatment, could another one like the TP53, or I think you said the
STK11,
yes,
KEAP1.
can those then show up and then cause things to change a little bit even more?
So there are some reports that state that you can develop acquired mutations in these genes. But the thing that's interesting is that for the most part, these are part of like the founding backbone of these cancers. So similar to like the KRAS gene, a lot of times those are going to be present very early in the cancer development. I think that's the third important point to notice that I think also makes KRAS stand out quite significantly from the other oncogenes. The other oncogenes, you basically have data saying that, okay, p53 co-mutations are associated with more resistance to treatment. There are some other genes like in EGFR, for instance, where presence of a p53 or an RB1 mutation, which is another gene that controls like division of our cells, that makes you more predisposed for a small cell transformation. But you don't have that clear role of the co-mutations spelled out and outlined as to what you have for KRAS and lung cancer.
Got it.
So it kind of reiterates that point that I mentioned previously about the heterogeneity of this disease.
So we've talked about like this could be someone that has a smoking history or may not. If someone with a smoking history were to quit smoking when they were diagnosed, is it too far gone that this gene will never recover and start working like a healthy gene again? Or is it one of those that where if you make lifestyle changes, you might see improvements in the cancer?
What I always discuss with my patients, the current smokers in particular, or the recently former smokers, is that the act of stopping smoking has a lot of benefits. So number one, there is data that suggests that if you continue to smoke during the course of your cancer treatment, it will increase tolerability from the cancer cells and it will increase treatment resistance and will worsen your prognosis and the efficacy of your treatment. So I think that that's benefit number one. Benefit number two is that we also have data that suggests that if you stop smoking, it will significantly decrease your risk of developing a recurrence of your treated lung cancer. Third point is that if you quit smoking, it will decrease your risk of developing another completely independent lung cancer during the course of your life. It will decrease your chances of developing other cancers in other areas. For instance, bladder cancer, throat cancer, esophagus cancer, mouth cancer. The fifth benefit that I list is that it will decrease your risk significantly of having heart and blood vessel diseases like heart attacks, strokes, as well as decrease your chances or slow down the worsening of COPD. So it's basically those 5 key points for lung cancer patients where stopping smoking is an absolute plus. And to your point, you should absolutely not look at this like, oh, the damage is done and now I'm just better off continuing to smoke. No, that's absolutely incorrect. And it's actually the exact opposite.
I know you're familiar with Dr. Antonoff and the trial with doing lobectomies in late stage lung cancer patients. And that is something that's talked about in our group. If someone's a smoker, even a recently stopped smoker, does that affect whether they would qualify for surgery as a late stage lung cancer patient?
So the benefit of stopping smoking before surgery is pretty much widespread. So I know that your question was about like an advanced disease, but even in earlier stages of disease, we actually recommend the patients to stop smoking at least a month in advance of their surgery, because we know that it decreases the risk of surgical complications after the procedure. And it also decreases the risk of you having a severe complication that in very rare cases could actually lead patients to pass away from those complications. So I would actually broaden your question and say, yes, it is beneficial to stop smoking, not only for patients with advanced lung cancer, but even for the ones that have early stage disease that are being considered for a surgical treatment.
In the younger population, and we're seeing younger and younger people being diagnosed with lung cancer. When I talk to people, they're not smoking cigarettes, they're vaping or they're smoking marijuana. Are the risk with that type of smoking just as high as traditional cigarettes, I guess?
So I think it's a bit early for us to say as high as cigarettes. Okay. But there is more and more emerging data that suggests that it is at least a concern and potentially harmful for the development of lung cancer. The magnitude of that, I think we're still working on quantifying, but it is definitely something that should not be a replacement to quit smoking. The best options to quit smoking still remain nicotine-based treatments with either patches or gum to kind of slowly wean you off the cigarettes, and also other medications that can wean off like the craving and the anxiety around wanting to smoke. So those are still considered like the standard treatments for quitting smoking. And there's a multitude of ways and access to patients to do that, either through their primary care physicians, their local pulmonologists. So it is something that's widespread and easily accessible to patients and their families. I think that's another key point of importance, because a lot of times what you see is that you have partners or children that have gotten into smoking, either with the patient, before the patient, as a consequence of the patient. So quitting smoking, at least in my view for my patients, is actually a family endeavor, because if one stops, it becomes really hard for you to sustain that indefinitely if you have close ones that are continuing to smoke. And those close ones are going to have the same benefit of quitting smoking as the patients, right? They may not have lung cancer yet, but all those other benefits that I described before, those are still going to be applicable for those patients. So the way that I like to approach this is make it like a family endeavor, where the whole family basically and all the family support system basically discontinues that habit, and therefore decreases their risk of health issues, cancer, cardiovascular, lung-wise, throughout the rest of their lives.
I'm from Kentucky, and Kentucky is a big tobacco state. So we do see, multi-generational families that are all smoking. So I could see where the support from the family members would be very important. Well, I think today has been very informative. I think that this is a good introduction to what KRAS really is, and just a good introduction level to KRAS and oncogene cancers. So I thank you for being here today. For those of you out in the audience, this is going to be a multi-part series. So make sure you follow us so that you can hear what is coming next. And I think that there's going to be some talk about kind of where treatment stands for KRAS patients right now and where it's going in the future. So again, thank you so much for being here. This has been a great conversation.
Thank you for having me, Leah. I really appreciate it.